bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, and the McMaster Children's Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities:
for quality and patient safety at CAFC, and I'd just like to welcome everybody to the call today. And before we begin, I just want to go over a couple of the technology pieces. As well as the presentation is going, I would encourage you to write any of your thoughts or questions in the question pane in the box on the in your control panel on the right-hand side of your screen. So if you can just write those in just as they come to you during the presentation, it's a really efficient way to do this, and that way you don't lose your thought. I think that's about all I have to let you know about today. So I'm going to pass it off to Darlene Bolivar, one of the co-chairs of CAFC's Patient Safety Collaborative.
Thank you, Lisa. Welcome, everyone, to the April edition of our Patient Safety Collaborative. As Lisa said, my name is Darlene Bolivar, and I'm from the IWK Health Centre in Halifax. My co-chair, who's not able to be on the line with us today, is Tracy Wrong, and she's from the Children's Hospital of Eastern Ontario in Ottawa. So today's presentation is the implementation of a rapid hydration protocol pre-chemotherapy. But before we get to that, I just want to mention to everybody who may be new to this collaborative in that we meet every month, the fourth Friday of every month at this same time, to bring topics that are pertinent in patient safety in hospitals, acute care, as well as community care, etc., that focus on pediatric patient safety within the hospital or community environment. So we would welcome anybody to join us. If you're new to the call today, feel free to jump online again next month, May 23rd at the same time. So to today's presentation, implementation of a rapid hydration protocol pre-chemotherapy. We are fortunate enough to have two representatives from CHEO, the Children's Hospital of Eastern Ontario, here with us today to overview what protocol they've put in place. Erin O'Shaughnessy is the advanced practice nurse for the Hematology, Oncology, Nephrology service at CHEO, and Jane Hilliard is the pharmacist in Hematology, Oncology, both from the Children's Hospital of Eastern Ontario. So without further information from me, I'm going to turn it over to both Jane and Erin.
Hi, everyone. This is Erin. So I'm going to go through the first couple of slides, and then Jane will pick it up when we move into the results of the study that we did. So the objectives for today, we want to describe the implementation of a rapid pre-hydration protocol prior to chemotherapy. We want to reveal parent and staff perceptions with respect to the rapid hydration protocol that we put into place. And we have some preliminary efficacy and safety data for the rapid pre-hydration protocol when we compared it to standard pre-hydration. So I've already heard from some of my nursing colleagues who were very interested in hearing what we had to say today. So welcome to everyone. So why did we want to do this project? Basically, this started as a quality improvement initiative. We started with a review of how we were functioning as a healthcare team, looking for ways to optimize and streamline care in, primarily it started in outpatient oncology, but has now moved to inpatient oncology. So we started discussing our chemotherapy admissions, and at the time, many of our patients were being admitted for overnight chemotherapy, often receiving 6 to 12 hours worth of fluid, and we just wondered whether this could be avoided. The patients that were admitted for chemotherapy overnight usually had either a urine-specific gravity or pH requirement, and often, despite our best efforts, patients didn't meet those requirements until late in the afternoon or even early evening, meaning that there was delays in starting chemotherapy, delays in discharge at the end of treatment because quite often what would happen is, particularly if we had a medication that was anaphylactic as part of the multi-dose chemo the child was receiving, we would call a physician and say, we're not there yet. We really don't want to start at 8 o'clock tonight, so can we push it to the next day? So then you immediately added a day's stay onto the patient's time with us. So in terms of other hospitals' experience, this idea was actually Jane's brainwave after having attended the PSYOP conference, and the literature that was presented at that time and what she subsequently was able to pull together looked at a number of different hospitals that had been able to do the same thing with their hydration. So CHOP, Children's Hospital of Philadelphia, put it in place as a comprehensive project to reduce chemotherapy errors. At the time, the only 10% of their chemo infusions were starting by 2,200 hours, which from a nursing perspective is extremely significant. Our folks up the road at Sick Kids had also attempted to do this, and they were able to reduce their hours of hydration from an average of 6 hours and 24 minutes to about 2 hours and 13 minutes by doing this rapid hydration approach. And they were able to improve the percentage of patients starting chemo prior to 1800 from 2.6 to 27%. So again, massive impact, particularly when you're on working on a nursing unit where your nursing census goes down at 1930. So you're working generally with one less nurse overnight. So workflow, workload, big improvement there. They will also be looking at some other factors that impacted their length of stay, such as late admissions. And I just recently was at a conference with them, and they presented their results, and they've got some other phases to the project that they want to go through. So Johns Hopkins as well, well-reputed institution. So they, in 2009, published in the Journal of Nursing and Quality Care that they had implemented a procedure that administered 20 mL per kilo of IV fluid over an hour to a max of 1 liter, and they would repeat Q1H until the urine parameters were met to a max of 60 mL per kilo. And they started hydration on these kids as soon as they knew for sure that they were a go from counts and they had a bed confirmed. After the protocol was implemented, they found that they've been able to decrease their mean time for meeting urine parameters from 4.9 to 1.4 hours, so in 45 patients. So again, a very significant time improvement. The next step in their process is to look at their chemotherapy delivery times, because that is now their rate-limiting process, and that relates to pharmacy resources, and that's the next QI initiative that they're going to address. So just a little bit of information about our CHEO Oncology unit, and we have 2 units that work together in a symbiotic relationship. So the medical day unit is our outpatient unit, and the kids start there. They are assessed for admission, their blood work is done, we make sure their counts are a go, and we bring them in if need be. The outpatient unit also does outpatient chemotherapy, so if the patient comes in and just needs an hour of cyclophosphamide or something like that, they're just going to go to the outpatient unit and then go home. But the inpatient unit takes the patient when we've got multi-day dosing requiring more intensive hydration, supportive care, and monitoring. So the patients that are getting the 5 days of ifosfamide, etoposide, that kind of patient model. We function with homegrown, standardized chemotherapy order sets, or pre-printed orders, that are signed by the oncologist or one of our nurse practitioners. We have one that works in outpatients. We don't, as yet, have computerized medication order entry. That is supposedly coming, but I think I will be retired before I see it. So why did we want to do this? So main goal, start chemotherapy earlier in the day, improves patient safety and improved workflow for all providers. And I've mentioned that our nursing census here goes down by 1 nurse at 1930, so that if we were giving a lot of chemo overnight, the workload is significant. We were hoping we would be able to shorten the hospital stay, both in the inpatient unit and in clinic, which obviously was going to translate to better patient and parent satisfaction. And eventually, we would like to see if this offers us the potential for more chemotherapy that can be done as an outpatient, where we don't actually have to admit the kid at all. So which drugs were we using? So primarily cyclophosphamide, so the higher dose over 500 milligrams per meter squared, our cisplatin and ifosfamide infusions, and higher dose methotrexate. And with the current leukemia protocols, particularly the low-risk protocol 0932, we're giving a lot of 1 gram per meter squared of methotrexate over 24 hours. So that was a big one for us. Exclusions, we basically followed on 6 kids' coattails with this one, and the exclusions that were identified when we looked at the literature: young patients, so patients less than a year of age, patients with history of severe renal, cardiac, or pulmonary impairment, and that's again for obvious reasons. You're bolusing with large volumes of fluid quickly. Patients with a brain tumor, concern around increased intracranial pressure there. Now we're just re-looking at that as a potential something we might change. And patients without a central venous line, again from a nursing perspective, blasting in a liter of fluid into a small IV on a smaller child over an hour is not going to be very good for your peripheral IV. So from a nursing perspective, there were lots of practice changes. Change seems to be our middle name here at CHEO of late. So outpatient clinic, as I mentioned before, previously we were admitting our patients overnight for hydration. So what would happen was the child would come into the outpatient clinic in the morning, have their blood work done. As soon as we knew they were a go and confirmed, we would access their portacath and then send them home or send them out and to come back to the inpatient unit at 2200 hours with a heparinized portacath that then the nurses on the unit would have to connect up to IV fluid and start on whatever the hydration was ordered to be. These patients are now staying in clinic until they're transferred to the inpatient unit. And if we know that we've got a bed for sure in the inpatient unit, it just may not be completely empty yet, or the bed hasn't been cleaned or whatever, we're able to actually start rapid hydration in the clinic. So again, getting on top of things much quicker than we were able to do before. So in terms of some of the other changes that we saw, outpatient clinic is starting the bolus fluids. If they discover that the child has actually met the required urine-specific gravity and or pH, they switch them over to the maintenance hydration as per our existing chemo printed order until the chemotherapy is ready to go. If the chemotherapy is actually ready from a pharmacy perspective, the outpatient unit has been starting the chemo in the outpatient unit prior to transfer to the floor, as long as we can ensure them that there will be a bed by the end of the day. So from the inpatient unit, it was a new approach to hydration in a subset of patients, so there was a learning curve. I was on the floor for the first few kids that we did just to coach nursing through the process. One of the hiccups that we encountered fairly quickly was that there wasn't a seamless transition to the protocol PPO at the completion of the pre-hydration PPO because they were separate pieces of paper. We've now integrated that into the PPO to express that once you've completed rapid, that you would move back over to whatever the pre-existing maintenance hydration fluids would be. So from an MD and nurse practitioner perspective, the main thing that they had to do when they were completing the chemotherapy PPO was be sure to indicate that, in fact, we were following rapid hydration.
So this is Jane. I'm going to be presenting pharmacy practice changes and some of the data that we've collected as a result of the project. So from a pharmacy point of view, by implementing rapid hydration, there was the potential for a shorter turnaround time for chemotherapy preparation if the patients are ready to start chemo sooner. So we knew that if the chemotherapy wasn't ready, then the nurses could just revert the patient to their standard hydration that's on the chemotherapy pre-printed order. As a result of some of the feedback that we received, we did revise some of our chemotherapy pre-printed orders to include the option for use of rapid hydration. So this was a response to some inconsistencies in modifying the chemo pre-printed orders when using rapid hydration. And by revising our chemo pre-printed orders, we were able to reduce the need for handwritten changes. So this is our pre-printed order for rapid hydration. It was basically adapted from the pre-printed order from sick kids. We did end up revising it a few times to clarify what to do when rapid hydration was completed. And one of our protocols had a slightly different pH requirement. So we had to add that into the pre-printed order. There were some practical issues, so ensuring that the hydration component of the chemo pre-printed orders were adjusted. We did a couple of low-tech changes. For example, for the prescribers, we posted some examples of what orders should look like in the area where the prescribers signed orders. We needed to work with our nurse case managers to communicate changes to patients and families who had already started on their chemotherapy protocol. So we had some patients who were already in the middle of their chemotherapy protocol when we implemented this change, so we had to explain to the families how their hydration and management was going to change. We also needed to do some planning for admissions, especially for those patients who previously would come in the evening before their chemotherapy, and making sure from a scheduling point of view that, that their admissions were changed. So our implementation steps included approving our pre-printed orders. So as per our usual routine in oncology, our pre-printed orders was developed by a pharmacist, prepared or verified by a second pharmacist, verified by an RN, and double-checked by 2 physicians. We provided a lunch and learn session to all of the different stakeholders prior to implementation, and our first patient started in February 2013. We also then had a stakeholder meeting about 1 month after implementation to discuss any issues, what was working, what needed to be adjusted. And some of the revisions that we made to our pre-printed orders was based on that feedback. So we submitted the study to evaluate our rapid hydration project to our local research ethics board, and it was approved. There were 2 phases. So we did a qualitative phase, which looked at the perceptions of staff and parents to the implementation of rapid hydration, and that involved a questionnaire for parents and structured interview with the staff at CHEO. And the second phase was the quantitative data, and it was looking at the safety and efficacy of rapid hydration compared to standard hydration, and included patients who received standard hydration, rapid hydration, or who had received both during their protocol. So phase 1 included parents of patients who received both standard and rapid hydration during their chemotherapy treatment. There were 5 of 7 parents who participated in this interview, and these 7 patients were the ones who were involved when we first implemented rapid hydration. So we recognize that our numbers are quite small. They rated overall rapid hydration to be the same, better, or much better than standard hydration, and did not perceive any negative impacts with rapid hydration compared to standard. And these were the questions that appeared for them, so relating to comfort of their child, any difference in quality of care, any difference or any concerns about how implementation was addressed to the parents. Were they satisfied with the information we provided? How did they perceive the timeliness of chemotherapy administration? And there was one parent who expressed that they thought that their child would start their chemotherapy a lot faster and got a little frustrated when it didn't. But we also had to remind them that there were also other factors that could influence when they started their hydration. And the parents were quite happy if they could be discharged a little sooner from the hospital. So that was some positive feedback. The rating scale was from 1 to 5, and we didn't get any 1s or 2, which were much worse and worse. So for staff perception, 16 out of 40 eligible nurses were interviewed. The nurses were interviewed until no new themes emerged in the interviews. All of the physicians and all of the eligible pharmacy staff participated in the interviews. So the 2 most common themes that emerged were decreased length of stay for our patients and fewer delays in initiation of chemotherapy. A number of the nurses really wanted to see proof that rapid hydration was superior before they would recommend it to other institutions, and no one really recalled any adverse effects. They felt that the exclusion criteria addressed possible safety concerns. Some of them thought they might see some signs of fluid overload, but they didn't recall seeing any differences. The main challenge that they identified was incorporating the rapid hydration pre-printed order into the chemotherapy pre-printed order. So we've already discussed some of the changes we made. Other themes that occurred were that most felt that they had adequate education before implementation, and most of them felt that there was not a significant change in their practice or responsibilities with respect to workflow. And although most staff felt they had adequate education, one of the questions that we asked them was to identify any opportunities for improvement if we were implementing changes in the future. So several suggested that hands-on education is really important in implementing any changes. For example, showing the physicians or nurse practitioner how to modify the orders and having the advanced practice nurse walk them through the first few patients would be really helpful. And as we've made future changes in different processes at CHEO, the hands-on teaching has definitely been a part of that. So the quantitative data is the one that people really wanted to know about. So it looked at data from January 2012 to December 2013. We had 26 patients, and those 26 patients experienced 117 different admissions for hydration pre-chemotherapy. So 102 of these were admissions through the medical day unit. 15 of them occurred for patients who were already inpatients at the time that their chemo was started. 7 patients received only standard hydration. 8 patients received only rapid hydration because they started their chemo after we implemented the process, and there were 11 patients who received both. So you may notice that we had 7 patients in the initial implementation phases, but we find that there may be individual needs for standard hydration at various points in therapy. For example, we had one patient lose his portacath partway through treatment and required standard hydration for a couple of courses. So here's the data. So for all of the hydration, so the time from start of hydration to the start of chemo reduced by about 3 hours, and that was statistically significant. The time to from starting hydration to meeting urine requirements also decreased. It was not statistically significant, and that may have been because there's just a high variability among the patients. We were concerned that when we started this, that from a pharmacy point of view, patients would be ready for chemo and we wouldn't have their chemotherapy prepared, but that didn't seem to be a factor. We were able to keep up with the chemotherapy. The reason that the standard hydration patients may have had a longer time is for some of those patients, their orders would have been written the day before for those patients who are coming in for overnight hydration. So you can imagine there'd be a very high standard deviation in the standard hydration results. The big one is the time of arrival in the medical day unit to discharge from hospital, and that was a difference of 26 hours, and that was both statistically significant, but also financially significant, and significant from a bed flow point of view in the hospital. One of the other things we were wondering about is, could we start our chemotherapy earlier in the day? We didn't have a high number of patients that started their chemotherapy after shift change, but that number who started before shift change increased even further with standard hydration and with rapid hydration, and that was statistically significant. More patients in the rapid hydration group required fluid boluses. In the rapid hydration pre-printed order, there is a fluid bolus built into the result and into the protocol. And for a standard chemotherapy pre-printed order, there isn't a standard fluid bolus if a patient is falling behind, so it relies on the staff to call physicians to ask for an order. So not having to actually phone for an extra fluid bolus makes a difference in the amount of fluid they receive. And extra patients more patients received bicarbonate boluses with the rapid hydration group. So it may be that with the single 1 liter bolus of half saline with bicarb wasn't quite adequate to help meet their bicarb requirements, their pH requirements. But we really can't increase the amount of bicarb in the fluid and still stay within the recommended bicarbonate dosing guidelines. We also did a comparison of just the patients who received both standard and rapid hydration. We took 1 episode of standard hydration and then the rapid hydration admission that occurred right after. So 2 contiguous hydrations. Again, the time to start to meet urine requirements was significant for the rapid hydration group. The number of chemotherapy admins that were started before 1930 was not significant. The numbers may look a little odd, and we're just verifying the actual numbers. You'll see that it's 7 out of 12, and we only had 11 patients. So we just have to take a look at that data. So not really significant numbers. The time between arriving at the outpatient clinic to being discharged the difference was about 22 hours, favoring the rapid hydration group. Again, not statistically significant with the high standard deviation and the small numbers, but certainly significant to our hospital. We needed to look at the safety of rapid hydration as well. There were 4 documented adverse effects possibly related to hydration, 2 in the standard group and 2 in the rapid hydration group. So no difference between the 2 groups. So our conclusions and where are we at now? Rapid hydration pre-chemotherapy appears to be safe and effective. It has become our standard practice for the patients meeting the criteria to use rapid hydration. We no longer routinely admit patients the night before chemotherapy for hydration. And so we have a decreased length of stay for some of the patients. We've maintained our exclusion criteria for now, and we may reevaluate the brain tumor group to see if we can just individualize it instead of excluding all of the patients, look at each patient individually, but that's for future discussion. And we do have a number of acknowledgements. Tracy Taylor, one of the pharmacists at Sick Kids in Toronto, was willing to share their experiences and pre-printed orders. Ramona Simonis and Sean Meredith were PharmD candidates at the University of Toronto, and Hilda Villarreal is the pharmacy research coordinator. And Ramona and Sean did all of the data collection and interviewing, and they all worked on the statistical analysis. MedBuy provided funding to evaluate the project, and the Director of Pharmacy, Regis Vaillancourt, certainly encourages research in our department. And a big thanks to the many disciplines that work together in our oncology service to we strive to continually improve care for our patients. And that's it.
Great, thank you very much, Jane and Aaron. I just want to remind everybody that if you have questions or comments, please, you can write them in the question pane in the control panel, or you can raise your hand. There's a little tool there to raise your hand, and I can try to unmute your line if you would like to speak directly to either Aaron or Jane. Darlene, I don't know, did you have any comments or any thoughts?
Thank you both, Aaron and Jane, for that. Great presentation. I know you're both pharmacists and presenting from the pharmacy perspective, but on the other end, it looks like it was fairly driven by pharmacy for patient safety effect, obviously. But I'm wondering about when you tried to roll it out, were there tips for success that made it successful and easily adoptable by people who this may have been a new practice for, and could you share those as well?
Erin is an advanced practice nurse in oncology, so we work quite closely together during implementation to try and we also worked with our Chief of Oncology, Dr. Donna Johnston. So we tried to ensure that nursing concerns, physician concerns, and impact on pharmacy were all taken into account as we try to improve this practice for our patients.
Okay, so no tips for how to roll this out if other people are going to go down this the same road?
I think make sure that all the stakeholders are on board. So that would be the biggest tip, and make sure that everyone is educated, everyone knows what's happening ahead of time. Getting our patients were on board, and the first couple of patients were very, very keen. So as we explained it to them, they had no trouble adopting the idea. And one of our parents actually said, "I've been telling you guys forever to just give them extra fluid to get them going." So she thought we might be a little behind the times.
Okay, thank you.
So did you have sort of education sessions with the nursing staff or with?
We did. We had we got input from some of the different nursing staff prior to implementing the project, and then we did some lunch and learn sessions to describe how the project was going to go forward, to show them what the pre-printed order was going to look like. We tried to address any concerns that they might have with regard to practice changes, and how it was going to impact their day-to-day workload. The outpatient clinic in particular at that time had undergone a lot of changes already, so they were already used to implementing new things. They'd already changed some of the way that blood work was done. They'd already looked at streamlining the admissions process. Erin, I don't know if you have anything else to add to that.
Well, from a nursing perspective, the main thing that we did, the nurses on my unit are quite comfortable with change because there's been a lot of it. So the first couple of patients that we did as an inpatient, I was simply on the unit with the nurse and walking them through the pre-printed order basically line by line to make sure that they were comfortable with it. And that's been a successful approach to implementing changes in the past, or when we have a drug that we've never given before. That's how I've always approached it, and that seems to work really, really well. The main thing with any type of change like this is really to implement using good change management principles. So involve your stakeholders from the word go, get lots of feedback, ensure that people understand why the change is being made, what the benefits are, as opposed to change for change's sake, and be open to revisions. So we use a quality improvement process that is a PDSA style of a framework here, meaning that we're constantly adapting based on feedback from staff. So the feedback was, the orders are confusing, we're not seeing how we are supposed to transition. So we went back and we looked at the orders again and said, how can we reword this better to make sure that it's clear to people? And then, when the changes were made, then I piloted the PPO by taking it to the nursing staff and saying, okay, does this make sense now? And yes, it did. One of the things that we did encounter was that for the methotrexate PPO, there is a bicarb order on the rapid hydration protocol, and there is a bicarb order on the standard regular pre-printed order for chemo. They didn't always match. So, and that was feedback that I received from staff. So I simply brought that back to the pharmacy team to say, okay, guys, we're getting two different bicarb orders. We got to pick one. And that was very easily addressed by just reminding the prescribers to be sure that the two orders align. So we just dealt with things as they came to us. Again, we use a PDSA framework for change here, so plan, do, study, act, and or plan, do, act, adjust, depending on how you take it. So, and that seems to work very, very well. But it's a very, very bi-directional process for change around here.
That's great. It sounds like you have a spectacular team. So,
I think we do.
Nursing and pharmacy very well together for a very long time, I think it's fair to say. We understand each other's roles fairly well, I think. So,
and people aren't afraid to give feedback, so that's I think it's really important to create an environment where people feel comfortable giving feedback.
So I know that Sick Kids uses this protocol. Do you know if any of the other children's hospitals in Canada have been using it?
Not that I know of. I know some of them are interested in it, but I haven't heard if any of the other institutions have started it yet.
No. So I'm just going to throw the question out to the people who are listening in to see if their organizations have used this or have thought about using this protocol. So just to throw that out there, you could just write in yes, no, and the organization that you're from. So I think that you've probably given everybody a lot of great information today, so lots to think about. So we don't seem to have any questions. So you must have told them everything they need to know just to run back to their organizations and get this going. I don't know. Any other thoughts, Darlene?
Sorry, I was chatting with a muted line. That I had done myself. Jane and Aaron, I assume you would be open to take feedback or comments at any point that other organizations may go down this road and need to have some help along the way as well?
That would be great. Yeah, we'd be open to that for sure.
Okay, so I know that Lisa has your contact information. I don't know if it was on your front slide or not, but maybe when we post on the Ken network the presentation, maybe Lisa could give your email coordinates as well for both of you. Would that be acceptable to you?
Yes, that's fine.
Okay.
Great. So just as a reminder to everybody that we will be posting the presentation here. You can see on hopefully you can see on your screen the Knowledge Exchange Network, and you will be receiving an email in the next day or two to let you know that when the presentation is posted. And if you have any questions at that time, or you want to share it with your other colleagues, like Aaron and Jane just suggested, they are quite open to answering your questions offline. So if there are no questions today, I think that we can adjourn a little bit early.
Perfect. Aaron and I'd like to really thank you for doing this and bringing this to light. I think you did give a very comprehensive overview of your the process that you used, and I commend you for actually moving forward and evaluating it in a research model, because we often don't use research to evaluate our process improvement changes. So good on you for doing that. And without further ado, as Lisa said, if there's no further questions, I think we can probably adjourn the meeting early today. And just a quick reminder that the next call will be May 23rd, open to anyone who would like to join us on the fourth Friday in May. So thank you both again very much.
You're welcome.
You're welcome.
Okay.
Bye, Aaron and
Thank you,
Jane.
everybody.
Bye.